What's up, everybody? Welcome to Pillosophy, a production of the Counseling Center in Portsmouth, Ohio. I am Senior Director Max Lyles, joined today with two very special guests. We've got Nurse Practitioner Larry Carter. Welcome.
Thank you.
And Pharmacist Andy Pierron.
Thanks for having
Fellas, I appreciate you guys being here.
Appreciate you being here.
Episode content for today, we're going to talk about medication-assisted treatment, what that looks like as far as the drugs that are used, the other interventions that go along with it, our philosophy as far as how those things are incorporated at the Counseling Center. But first, always like to qualify our guests. So whoever wants to start first, you're going to the pharmacist first. Andy, give us like the bio of what all you've done, what you're doing now, sort of how you wound up in front of the camera here today as the pharmacy expert, man. Give it to us.
So about 20 years ago, I started doing pharmacy, retail pharmacy in this area.
Okay.
Of course, I've witnessed the pill mill crisis. You know, it's like watching a train wreck in slow motion over 20 years. As I got a little bit bored in pharmacy, I started doing disease state management. And what I started seeing when that was happening, just going into businesses and trying to help people improve their health. Then I started seeing how other addictions played into it. And in the same time, I started looking around at, you know, just how when someone is addicted, how they just kind of go from one substance to another.
Yeah.
Like I get someone to lose weight, but they're smoking more, get someone to stop smoking, and they're gaining more weight. In the meantime, this opiate crisis keeps going on.
Yeah.
You know, just been around the towns, been around the bars, and seeing how, you know, when you turn 40 years old, you start seeing how alcohol starts affecting people's lives. So that was just all kind of coming together at a time when the Counseling Center was growing. So it just became kind of a natural integration over time. So,
Cool, man. Yeah. So then tell us a little bit about what you're doing now in the field.
So what I do mostly right now is I still do a little bit of immunizations and work with the companies a little bit, just provide a value-added service back to our community a little bit. But mostly what I'm working with is just what we're going to talk about today, about, you know, just learning what the different options are as far as MAT. I mean, I think most people think of MAT as methadone or Suboxone.
Right.
And of course, there's pros and cons to that for
Absolutely,
sure. But there are other options as well, and try to teach people those other options and where they may fit in their recovery. So. Yeah,
I got you, man. Cool. Hey, well, thanks for coming, man. Absolutely glad to have you here and all your experience. Larry, same thing, man. Give us a little bio. How you wound up here today?
Well, let's go back to 2000 when I joined the military.
Okay.
Did 6 years in the military and did an overseas deployment. So I got to see the world. When I got out of the military, I came back home and got into law enforcement, became a deputy sheriff, and that was back in 2006 at the height of the pill mills. And then
I had no clue. That's awesome.
So I did that for several years, and unfortunately, I got to see some of the darkest areas of our county and how the drug addictions were crippling us, families torn apart for nothing. So I decided in 2009 that just needed to do something different. So I went back to nursing school.
God, talk about doing something different.
That's a deputy
sheriff, being a nurse practitioner. Gosh, you're like all in now with both feet.
So during school, I got into some of the mental health classes, and I really enjoyed that. So whenever I got done with school, I knew I wanted to go on and be a nurse practitioner through that time. So when I graduated nurse practitioner school, I took a job with the Department of Veterans Affairs, you know, to help the veterans out. And I got to do a lot there. And then here back in September of last year, I got an opportunity to really come back into our community and help our community heal from the opioid crisis. So that's how I landed here.
What was anything you'd learned that's been like, you know, something that's like defined kind of your practice since transferring over and getting to work with veterans or whatever, man? That's I didn't know about that transition. That's awesome.
Yeah. One thing that I kind of knew going into working with veterans was going to be mental health, because as a veteran myself, I knew that's a huge thing. You know, we're losing 22 veterans a day to suicide. And so I just kind of picked up from that and then brought that over with me here to TCC. And that's every patient I see is, hey, you know, how's your mental health? Let's work on things. Talk to me. So.
That's what's up, man. That's awesome, dude. Well, hey, definitely two experts, right?
I don't know.
Lots of different experiences in the room. Yeah, lots of different life experiences in the room. And then you guys got me, so good luck. Next thing I wanted to talk about was you had mentioned when people think about MAT, it's normally just those hot topic drugs that people think about, methadone and Suboxone. So first, let's talk about like what those drugs are, and then how sort of they can be used, and then sprinkling some of the other things maybe that people don't think of when they think about medication-assisted treatment.
Yeah, so early on, we had methadone. That was the big thing for many years. The problem with methadone, though, was you needed daily dosing, and there wasn't the naltrexone binder in it to keep it from being misused, unfortunately. So when we started seeing more of the MATs coming up, we're seeing the Suboxone, Zubsolv is the generic that we use here. And it's very helpful because it's got that binder to it that allows the medication to be dosed a longer period. We can do a week at a time instead of having somebody come in daily. So that's the first big step.
And now I think even too, like, methadone's one of those things of like, it is certainly an option for treatment, right? But it does have like its own barriers, right? With the way that it's regulated, you got to show up to the place every day to take the medication. Like that's a barrier in and of itself, right?
And with that, that leaves us more time for some of the group and individual counseling for somebody that's in recovery, because you're not going to the health clinic every day. You can use that other 5.5 days of the week in order to get some of the help.
Yeah, that's and then talk about from a pharmacological standpoint of like, when you say methadone, how does that work as far as like I take the drug and then sort of what happens?
So methadone
within the patient.
So as you were talking before we started, so methadone is a pure agonist, right? With high affinity for the receptor site.
So pure
binds,
agonist means that it's just the partial opioid.
It's no
good.
Exactly. Right. With high affinity to the receptor site. So that means it's long acting.
I got you.
So that's where it's used because you don't get the highs and lows that creates a craving. So that's where it fits. Suboxone, as you were talking about, is a partial agonist, antagonist. That gets confusing. Because really it kind of depends on the product and whether it has more of an agonist effect or an antagonist effect as to where it fits in therapy. Suboxone, I think, is probably the best known agonist antagonist in which it takes away the craving.
And that means that it's got the opioid, partial opioid, and then a blocker.
It does, yes. Yeah, and that's where, like, they're seeing it now where people are coming in on fentanyl, and you give them Suboxone, it's going to throw them into withdrawal.
Precipitated withdrawal.
Exactly, because it's not, so, and then to titrate that becomes very hard. And then naltrexone is a pure antagonist in which all it's doing is blocking. So I always explain naltrexone is kind of the brother of Narcan. Everybody knows what Narcan is, right?
That's a good way to explain it.
Naltrexone is just, Narcan is just the little brother that's real quick, gets the receptor site real quick, knocks off the opiate, but what's it do? It goes away real quick, so you have to narc them again. Naltrexone, just think of it as a big heavy stepbrother, gets there real slow, attaches the receptor site, a little bit harder to knock off, so it's longer acting.
I got you.
But they both do the same thing.
All right. So then we kind of outline that, like your agonist drugs, full on opioids or partial opioids, then agonist, antagonist drugs being things that are a little bit of both, and then full antagonist drugs that are blockers only, right?
Yes. Right.
So then one of the things too that you hear about with Suboxone and being like a partial of both is that like the abuse potential's lower, right?
Yes.
As one of the things that you hear about that. I don't necessarily know how much that's true, rather than then I just believe that the way that it can be like prescribed and monitored and looked at and used and like coupled with treatment are the things that really take that abuse potential down lower. You know what I mean?
Yeah, part of the thing that lowers the abuse potential of that is the Narcan element in it. Now it can still be misused, meaning somebody may find it elsewhere, not prescribed.
Absolutely.
In order to
diverted, I believe is the term.
Diverted.
Am I doing that right, Pharmacist?
That is right.
And use that to help with those withdrawal symptoms, because that's essentially what it's doing, is helping to reduce the amount of symptoms you're having.
Right.
So misuse is there. Less chance of abuse, though.
Yeah. I think that the way I always describe those drugs that are either full agonist or like partial is that it's like fire. Like fire in your fireplace has a lot of positive potential, right? Like I can heat my house when it's cold. It can give me light. It can like keep the house warm, cook food on it. Fire's a great thing, right? If I take fire out of the fireplace, what happens?
It's no bueno.
I burn my house down, right? It's like that's an analogy. It's like you were talking about the different tools, right? And the way that those things can be used. But that's always been my analogy with the MAT drugs that are used, is that no drug is without a risk potential.
Right.
And so that's what like, this conversation we'll get to that, but it's like the people that are utilizing these drugs in conjunction with therapies, we're trying to mitigate that risk to have the maximum potential for the client.
Right. And one of the things that I truly find fascinating about that and walking that line is the component of self-prescribing.
Yes.
You know what I mean? Yeah. So you end up with the person that just starts self-prescribing, right?
Yes.
But then you also, and you know from working in this industry, it becomes harder when the person has gotten a legitimate medical condition for which they've been prescribed that.
Yes.
I spent hours on the phone earlier in the week with a guy out of Michigan who he thinks ketamine is the solution to his problem, right?
That's not medically assisted treatment.
It's not a nasal spray. But
if you need to put me in a K-hole.
But he's already made that decision. He's already self-medicating for that. And that really is the line that gets drawn there when you talk about the fire in and out of the fireplace. Yeah, as long as it's in the fireplace, it's great. But as soon as you start manipulating your thought process and using how you're taking it out of the fireplace.
And I think that's one of those, I don't know if you'd call it a phenomenon or just a symptom of working with the substance use disorder population, is despite the fact that when we come to treatment for help that our life might be in shambles at that point in time, I still believe that I know what's best for me.
That's exactly right. That's exactly what this gentleman's doing.
The other side of that coin is, from a clinical perspective, the addicted person is the expert in their own life.
Yeah.
But the plan needs to be created with a professional from the outside looking in, right? It's that old 12-step philosophy of the same brain that you thought yourself into the problem with is not going to think you out of the problem.
Yeah, right.
So while it's important for a person to have some say-so about what you're willing to do and what you're not willing to do and those kind of things.
Well said.
I think it's always important to consider like the professional's input into that scenario, right?
Right.
And that's part of our first initial visit with them.
Good.
When they come into us, we talk, hey, how's your life now? Tell me what's going on. And
that's a loaded question.
Yeah.
You know what I mean?
Well, and that's the best way
how much time you got,
right? Things up. But part of that is, hey, this is what we can do for you, and this is how it helps, and this is why we do it this way. Yeah. And that kind of helps them get into that mode of, hey, time to take a step back and let the treatment work. We're assisting them, medically assisted treatment, and that's our whole goal is to help them out.
And that's the other thing too, to get into that philosophy of it's medically assisted treatment, medication assisted treatment. So it's the use of certain medications in conjunction with other therapies and clinical interventions that are like leading that whole process, right?
Right.
So you were talking about an analogy that you like to do that, and talking about the different tools. Give us that one again.
Yeah, so we got to think of recovery as you building a birdhouse, okay? You can go into building a birdhouse with nothing, go out into the woods, find what you need. You might build a birdhouse, you might not,
Depends on how,
you might be successful, might take you months, might take you years, might never happen. However, if you've already got the wood in place, and then you bring in a hammer, it's going to make it a little bit easier. You may not get it built, just a hammer. You would have to find something to nail it down with. But that's when you bring in the nails. That's another tool. So with hammer, nails, and wood that's pre-cut, your birdhouse is built.
Right.
I mean, it's easier to do it that way, and that's how we look at recovery. You've got medication, your hammer, and then you've got nails, the treatment, the counseling, the group, the individual treatments.
Sure.
And that is just the easiest, most straightforward way to build a birdhouse.
Yeah. Yeah, I love it, man.
Along that analogy, yeah, you do, but you don't use a sledgehammer.
Right, exactly.
You got to use appropriate tools, right? You have to use appropriate tools for what a person's got going on.
Exactly.
You might not need a nail gun. Hammer will work.
Yeah. You might not need a high-powered nail gun. I got it, man. I got it.
Yeah.
So then that kind of leads us into the way that we use medications here, the way that we interject those clinical interventions into things. Talk a little bit about the phenomenon of sort of what we're trying to avoid with like the symptoms of early sobriety. So I go into my first meeting with Larry. He said, "Hey man, how's your life?" And I totally just unload on him, right? Right. And so you're going to hear a big list of problems, right? And in the United States of America, we love to prescribe a medication for a problem, right? Talk about that phenomenon of, hey, doc, I need this for that, and now I need that for this. Talk about what you've seen play out.
The prescribing cascade, you like to refer to.
Yes.
Yeah, you go into the doctor and you're like, doc, I'm, really having a hard time sleeping, as you're talking about.
Boy, do I.
Yeah. And so you prescribe something for that. Well, the next thing you say is, I'm really feeling sluggish through the day.
In the mornings when I'm waking up,
something for that. And now, in the afternoon, I'm really starting to get, some anxiety. Is there something I can take for that? So you prescribe something for that. And pretty soon you're working your way right back into where you were with medication, And usually what I tell people is like, you can go out and relapse. You can go do this prescribing cascade, which I would be a little bit more favorable if I saw favorable outcomes.
Sure.
But you just don't see the favorable outcome. You follow that person for 5-10 years,
right,
and they either relapse or their other medical conditions have worsened.
Yeah.
The majority of the time. Now, you always have these outliers, when you start doing the bell curve.
Well, there's some people that can build a house without the tools.
Right.
There's some people that can build a birdhouse without the tools.
Good point. Yeah. But for the most part, what you're going to see is poor outcomes over a 5-10 year period of time if you don't continue to work in a way that progresses in a healthier lifestyle.
Right.
Yeah.
So then to avoid that from the prescriber side of things, what are some sort of like strategies we're trying to do if I'm a person that presents at the admission center and I have a high risk for withdrawal potential and I'm looking at getting managed either like in a at the withdrawal management facility, or if I'm looking to manage that detox stage in an outpatient basis or whatever? What does that sort of like look like from the start of things to then how it progresses? Walk us through that.
Right. Low, slow, and as needed. That's my philosophy.
Slow, and as needed.
Exactly.
It's a great philosophy.
So there are certain medications that we have in our protocols that they can have as an as needed basis. You start having an upset stomach, we can give them some medication for that.
Sure.
Mental health medications, unless they've got a bona fide history where they've been treated before they came to us, we like to avoid those, especially in the very beginning, because drug use, it affects our pathways in our brain.
Yeah.
And what we find a lot of times is once we get started on the treatment, those mental health symptoms start falling down.
Well, a lot of those complaints are what we like to call symptoms of early sobriety.
Yes,
like an inability to get a good night's sleep is one of those symptoms of early sobriety, right? And that's and it's one of those unfortunate things with the nature of drugs these days. It's sort of hard when you have a person say that's been using narcotic drugs on the street. There's not really a process to you don't know what you're taking all the time. A psychotic episode and a meth-induced psychotic episode, you're going to need some time to untangle that stuff, right? Low, slow, and as needed. I'm going to steal that, maybe put on a shirt, hit the guys up at the lab. Yep.
One of the things we're really fighting right now is that you can make that look like a bipolar disorder.
Right.
And we only have patients for 90 days, inpatient, and really it takes that long to kind of get to a
90
point
days to 6 months
to where you can see, okay, was this an underlying condition or was this a symptom of their use?
Yeah.
And you just don't really, so the low, slow is really good because you don't, first do no harm. We really want to take it so that we're not pre-diagnosing conditions that were really part of the drug use.
Sure. I know in talking to another nurse practitioner one time about just diagnosing and prescribing and those kind of patterns, and then kind of that phenomenon when everybody kind of can wind up on the same medication with the same diagnosis kind of deal. It's one of those things of like, how did that happen? And the talking to another nurse practitioner, they told me, they said, well, you don't necessarily have a medication problem, you have a diagnosis problem. That, you know, I wouldn't just pin that on someone after meeting with them one time. That's a diagnosis, because diagnosing is the same way, low, slow, right?
Exactly.
So like start with your minimal things and then move forward as you get to know someone
Yeah,
better.
that methamphetamine, I can go back into my 1992 pharmacology book and read to you the symptoms of abuse of cocaine and methamphetamine, and psychosis, cataloging, you know, that that pleasurable suspiciousness. And it's really hard to slow our clients down because they're having all those symptoms. To say, look, this is a symptom of that condition, because they're taking notes and they got it figured out, right? Because that's
I have a plan for my life. You know what I mean? I have a plan for my own life.
And luckily, the way our treatment program works, though, you know, we have an inpatient stay 90 days, but then a lot of the times we get them into transitional housing, so we can have time with that patient for up to, you know, a year.
Right.
So, you know, we start seeing 6 months, 8 months down the road, they're coming in, they're saying, Larry, man, I'm sleeping great. I don't think I need that medicine anymore that you gave me in the beginning. I said, okay, well, let's take that off. They come in next time, hey, I'm doing really good. I got my court cases settled, for example, and my anxiety's gone now. Okay, let's take away that as needed medication then. And by the time they get through graduating through the transitional program, some of them are without medication.
Yeah, they're just receiving primary health care, those kind of things. And that's the other part too, you know, this whole idea that, well, we need patients, we need clients, and that's what makes the business go around. Our goal is not to create a lifetime patient. We want to create a 1-year patient. And we want to take that person from super high potential for withdrawal and walk them all the way through to taking as few medications per day as possible. Because the other part about that stuff is taking all those medications, I have to manage that as the person taking them. And then that creates another barrier. So like one of those things we were talking about, like with methadone, like the barrier of having to get there every day. Well, then it's a barrier with mental health medication, and a number of those is that I got to get them refilled all the time, that I got to remember to take them every day, that I got to hope that I'm at a point where I can manage that, right?
Yeah, it's my insurance. It's something I'm with my insurance. It's not covered. It's not. Now what do I do?
I think there's a lot of things that's sort of a responsible use of those things. Back to the fire analogy, right?
And even more, we're giving them tools for their toolbox during that time, not just medications. Medications are just part of it, as you know. You know, we're doing coping skills. We're doing deep breathing exercises, teaching them how to take a step back and realize, hey, you know, let me look at this picture from a different perspective, and maybe I don't need to get as worried about it. Things like that. And during that transitional period is when we can take that opportunity to do that. And then like through those things, in addition, because like while every person is seeing a prescriber, taking medications that they need on a low, slow, and as needed basis, right? They're also involved in a treatment program. So that can be everything to, like, you know, 30 plus hours of services a week in residential treatment, all the way down to I'm stabilized and I'm doing mental health therapy once every other week with a licensed therapist or whatever, right? On top of things like job training that we offer. So, I mean, we're just trying to set them up for when they leave our services, they're going to be successful.
It's amazing how important that structure is. Because like if you try to wean somebody off Suboxone on an outpatient scale, your success rate is ridiculously low, almost to the point where you have to question whether it's even realistic or something you should be doing.
Because then you get into that do no harm. Is the person just safer with the long-term lower dose, right?
You take that same patient, you put them in the structure of housing, and now all of a sudden, you know, the majority of the time we don't have problems. It changes that dramatically based on their surroundings. It's incredible.
And then talk about that sort of timeline of what that can look like on an individual basis, short of like quick, dirty, in a hurry taper to like how long we're able to work with somebody to like manage those things through the various medications.
And it all goes back to that initial appointment. Where are you? Tell me about your use history. You know, you've only been using for less than a year. Okay, you may not need that heavy taper. Okay, so we would look at that different from somebody that uses 5 grams of fentanyl a day when they're coming into us, because that's a lot. That's a tough treatment. So initially we try to get them from point A to point B in a matter of 6 to 8 weeks. Okay, our goal is abstinence based treatment.
Sure.
Meaning we try to get them down off the Suboxone and into that point where we can give them Vivitrol.
Right.
Okay. Vivitrol for opioids. Okay. Other options for methamphetamine abuse or cocaine abuse,
Sure.
Camprosate, and Andy will be able to speak a little bit more on some of the different treatments.
Sure.
But that's our goal.
Yeah.
6 to 8 weeks during that first 90 days.
And that's when
into
we're
the
looking
Vivitrol.
at using those like agonist or partial agonist
Correct.
antagonist drugs, right? But then the use of Vivitrol can go on for
as long as we need it.
okay.
Yeah.
So as long as the patient feels like they're benefiting from having the blocker on board in conjunction with
but that's where I try to be careful because
Okay.
you're right on the first part. The National Institute of Health says the longer someone takes it, better chance they have a lifelong sobriety.
Okay.
But if that person had a heart condition, we wouldn't say, hey, just let us know when you want to stop taking that, would we?
Yeah, you're absolutely right.
No, that person would come to you and say, how do you feel about me going off of that blood pressure medication?
Right, yeah.
And we would do some other things to see if that would be appropriate.
Okay.
Vivitrol should be the same way. And
Okay.
what's happening routinely is that people kind of take that on their own shoulders.
So what you're talking about is the same phenomenon of the person comes in and they have a plan for their life?
Yes, that's right.
To change the plan that I'm not going to take my Vivitrol anymore, that's something you would hope from the pharmacy side that they would be talking with their provider
That's
about.
right.
Okay.
And plant that seed.
Yeah.
You need to be asking about this, not just decide, hey, this month I got a lot going on. I don't think I'll go
I
in
know
for
what
that
I
shot.
need.
Yeah,
You know what I
right,
mean?
right.
I know what I
Because
need.
now you can see it. That's where they start
Yeah.
to transition back into controlling
Yeah.
things that they probably shouldn't be controlling
Yeah.
at that point.
Yeah, absolutely.
But to kind of go back on your question, there is no, in my eyes, there is no upper limit of the amount of time we can do it.
Okay.
Okay. You monitor things like liver function and health of the individual.
Yeah.
But if we need to do Vivitrol indefinitely, we're going to do Vivitrol indefinitely.
Sure.
So-
Yeah. Just one of those things that you want to have some input with it.
Exactly.
Right? I got you.